So in this lecture, we'll be discussing about the conditions of the scrotum. Probably this would be the last lecture about the genital conditions, particularly since we have been discussing the genital system, and we have discussed so far about the conditions involving the epididymis, the conditions involving the testes, and now today we'll be talking about the scrotum conditions, surgical conditions which are related to the scrotum. And with this, that would be the end of our genital part of the general surgery course. So the first thing in today's lecture we're going to discuss today is about the Fournier's gangrene. And Fournier gangrene is kind of the necrotizing fasciitis, and it's if you could look at the picture, it's a typical there's excoriation of the skin, and whole of the necrotic area is being sloughed off with a collection of the pus. And you can see here that almost all of the epidermis over the that particular area that has gone and shed off. Most commonly, the Fournier gangrene is involving the genital system, like the external genitalia, plus a little bit part of the thigh and upper part of the lower limbs. And if we particularly talk about the Fournier gangrene, so in this particular entity, there is a kind of it's a kind of the acute inflammatory process that ultimately lead to the obstruction of the lymphatics and obstruction of the blood supply, particularly causing the blood vessels to be obliterated. So because of that obliteration of the vasculature, the blood supply is compromised, and it ultimately lead to the to necrosis, and ultimately leading to the gangrene. So if we particularly talk about the characteristics, there's a polymicrobial infection of the soft tissue, and first of all, there is a kind of the necrosis in the skin, and necrosis secondarily to the compromise in the blood vasculature. And the most common and the most important thing in this Fournier's gangrene is a typical, because there's a lot of debris, there's a lot of the inflammatory cascade, and because of that, the patient can ultimately go into sepsis. The most important thing in case of the Fournier's gangrene is that there's a typically microbial invasion of the soft tissue, particularly the external genitalia and the part of the skin and the part of the scrotum, and ultimately involving the whole of the external genitalia, the part of the thigh, the upper thigh, and the upper part of the lower limbs. If we particularly talk about the onset of Fournier's gangrene, let me tell you, it's a kind of the acute inflammatory process, and with this, the patient will complain about the fever, the pyrexia, and there would be a kind of the swelling, and ultimately that swelling will lead to the necrosis and sloughing off of the epidermis, and causing a lot of the whole of the necrotic tissue that gets sloughed off ultimately on its own. And the onset of the gangrene is sudden, and it leads to the exposure of the contents of the scrotum, and at times the testes are exposed to the surface, but they remain healthy. And the most important consequence, which we are mostly worried about in the Fournier's gangrene, is the development of the sepsis, because it's a kind of the infection which is involving the necrotizing fasciitis, and we all know that the necrotizing fasciitis is a kind of surgical emergency, and we have to resuscitate the patient, we have to hydrate the patient as soon as possible, and obviously we have to treat the sepsis as well. And it can be a localized sepsis involving the genitalia, the testes, the epididymis, and the perianal region, and sometimes it can cause a generalized sepsis of the body. If we particularly talk about the causes of the Fournier gangrene, let me tell you that most of the time, at least after the minor injuries, like there can be a bruise. The other thing, there can be like scratches. There can be infection, kind of the little bit infection, then spreading on later, and there can be because of the injection of the hemorrhoid, there can be urethral dilatation. It can be because of the post-urethral dilatation, and there can be periurethral abscess. So actually, if there's a smaller focus of the infection present on the skin, or even because it's a polymicrobial infection, and it's not that only one organism is involved. There can be multiple organisms involved in this Fournier's gangrene, and because of that, the causative agents leading to the Fournier's gangrene is like bruises, scratches, injection of the hemorrhoids, like injections, cryotherapy. They can be produced post urethral dilatation. They can be periurethral abscess. All these can actually lead to the Fournier's gangrene. Now, another important thing about the Fournier gangrene is the characteristic. And if we particularly talk about the characteristic, I told you it's already a mixed kind of infection, and it's a polymicrobial infection. So it's not that only there would be invasion of aerobes or nubs. Both of the aerobic bacteria and the anaerobic bacteria, they are involved. And ultimately what they do is, there are some kind of the smaller arterioles which are supplying the scrotal skin. So what happens is, like, those arteries, actually they are obliterated, and because of the obliteration, because they cause kind of the endothelial injuries, and in that, because of the obliteration of the arteries, the blood supply of the scrotal skin is compromised. Because of the compromise of the vasculature, ultimately deficiency of the blood, and when the tissues are deprived of the blood, and the tissues are deprived of the oxygen, ultimately the process of the gangrene gets initiated, and ultimately necrosis and gangrene, and the result is a Fournier's gangrene. The important thing about this is they spread to the fascia, they spread to the skin of the penis as well. But the good thing in this, that it only involves the fascia and the skin. They do not mostly spread to the deeper tissues, and that's why the testes, although they are exposed, but the testes are, even after the exposure, they remain healthy. And sometimes when there is severe kind of the necrotizing fasciitis, they can ultimately spread to the perineum and the abdominal wall. And we know that whenever the infection spreads to the perineum and the abdominal wall, it leads to the generalized peritonitis, and because of that, the patient actually, it's a kind of emergency, and ultimately the patient has to be treated on urgent surgical basis. So talking about the clinical features, there can be crepitus, and there can be smelly exudate, there can be eczema, there can be excoriation of the skin, there would be gangrenous patch which is quite visible, there would be sudden pain in the scrotum, and the condition would be just like the testicular torsion, but typically you would see a gangrenous patch over the skin of the scrotum or the external genitalia, and obviously it's a kind of the infective process. So we all know that the infective process, there is pain, and there is a pallor, and there's pyrexia as well, and the patient presents to you with a very high grade fever, and ultimately cellulitis ultimately spreads rapidly, and it will lead to the sloughing of the epidermis and the dermis, and you can see the necrotic patchy areas of the skin, and ultimately you can, because necrosis ultimately will lead to the gangrene, and the gangrene ultimately would be visible by the naked eye. So particularly if you talk about the treatment, it's a kind of the acute inflammatory process. So what you do is you need to give the patient a good supportive control. You need to put the patient on a good hydration therapy. You need to resuscitate the patient. You need to put the patient on IV antibiotics. And if the patient is diabetic, or if the patient is hypertensive, the condition usually worsens. So you need to control his hypertension as well. You need to control his diabetes as well, because obviously we know that the higher glycemic index and the higher level of the glucose in the body, they actually interfere with the healing process. And when the process of the healing is affected, obviously the gangrene would particularly will be unstoppable, and it will ultimately lead to the sepsis. So what you need to do is you need to put the patient on good intravenous fluid resuscitation. You have to put the patient on broad spectrum in IV antibiotics, and ultimately you need to excise the dead infected tissue. This is something very much important. Regarding, first of all, you do not do the surgery immediately. What you do is you just resuscitate the patient. You have to just you do kind of a debridement, and you slough off the necrotic patches, and you have to take care of the wound. Plus you have to give a good IV antibiotic cover, particularly if you want to put the patient put on a penicillin group if he's not sensitive. You can also add a linezolid group as well. And with all these things, the supportive therapy which you are giving the patient, like the good hydration status and the broad spectrum antibiotics, you need to put the patient on a regular basis of surgical debridements as well. This is something very important. It's not only that you have to debride the wound only, but as much as deeper as you can go, and you have to identify the necrotic area and the extent of the necrosis. So you need to excise all of the dead tissue, all of the inflammatory process, and all of the necrotic area. Plus what you need to do is, because most of the time it's the skin and the subcutaneous tissue, and most of the time if you do not intervene, it goes on spreading, and it spreads very rapidly. So what you do is there can be a large area of the skin which is particularly involved. So for that, you also do regularly vac dressings and regular debridements and regular wound washing, and then ultimately when the wound is healthy, all of the slough in the necrotic tissue is gone, and after the vac dressing, the granulation tissue is already there. So what you do, you can put the graft as well, and you obviously the partial thickness graft or the full thickness graft, depending upon the place and depending upon the extent of the necrosis as well. So this is what you need to do for the Fournier's gangrene. Always remember, it is a acute inflammatory process. It is a polymicrobial infection, secondary to the bruises, minor injuries, scratches, a post-hemorrhoidectomy, or injection sclerotherapy, or periurethral abscess. So all of these things ultimately can lead to the formation of the Fournier's gangrene. And the pathophysiology behind this is actually it leads to the obliteration of the small vasculatures which are going to supply the scrotal skin. So whole of the scrotal skin area that's sloughed off, that get necrosed, that get gangrenous because of the deficiency of the good blood supply and good oxygen availability. So you have to put the patient on a conservative treatment, and you have to excise the wound as well, put the patient on a good IV antibiotics, put the patient on a good hydration status. Sugar monitoring and blood sugar control is something very much important. And ultimately surgically you need to excise the wound, and also you need to you need to excise and put the patient on a daily vac dressings. Particularly, in case of the extensive necrotizing fasciitis of the Fournier's gangrene, there can be urinary and fecal contamination as well. So sometimes you can do the urinary and the fecal diversions, and vacuum assisted dressings. They're also part of the treatment strategies for the Fournier's gangrene. Another important thing, including the conditions of the scrotum, is a filarial elephantiasis of the scrotum. So their elephantiasis is sometimes, it's like the skin is enlarged and there's a large cellular swelling, and it's just like, and the skin gets thicky, scaly, like the skin of an elephant. So bigger and thicker skin and large lesion, that is the elephantiasis. So there can be a filarial elephantiasis, or there can be a non-filarial elephantiasis. So the filarial elephantiasis is secondarily to the organism Escherichia bankrofti in almost 90% of the cases. So you can see here in the diagram, it's involving the scrotal skin, which is deep down, extending to the mid thigh almost, and this is a kind of the disfigurement in a very bad condition as well. So if we particularly talk about the characteristic of the filariasis, actually Escherichia bankrofti is a kind of worm, and what it does is like it obstructs the pelvic lymphatics, and we know that whenever the pelvic lymphatics is obstructed, there's obstruction to the lymph flow, and it goes on occupying the space. There's a collection, and ultimately it leads to the elephantiasis. So if it's because of the condition, secondarily to the infection, secondarily to the Escherichia bankrofti, like in case of the 90% of the cases, then this is called as filarial elephantiasis of scrotum. Besides that, we know that it's a kind of infection which is very much common in the tropics, and it's usually transmitted by the mosquito, and particularly there can be superaided infections as well, like the lymphangitis, because obviously when there's a obstruction to the lymph flow, there would be stasis of the lymph, and there can be superaided infection causing the lymphangitis. And ultimately, because of that, there can be swelling of the genital area and the swelling of the lower limb, because we know that all of the lower limb drainage, lymphatic drainage, is going to the pelvic system. So whenever the pelvic system is obstructed, there is the swelling of the genital region, plus there is swelling of the lower limb as well. So the filarial elephantiasis, clinically the patient will present to you with a large swelling involving the scrotum, and sometimes there would be swelling of the lower limbs as well, and there can be superaided infection like the lymphangitis, the swelling. So the swelling can be red, and patient can present to you with a pallor and pyrexia and the pain. And you always keep in mind that this is secondarily to the obstruction to the lymphatic vessels, pelvic lymphatics particularly, and they're very much common in the tropics, and they're transmitted by the mosquitoes. So talking about the signs and symptoms, fever, pyrexia, this is the first cardinal feature, because it's a secondarily to the lymphangitis. The patient can present to you with a fever and pyrexia. There can be chyluria. Chyluria is a condition in which actually, secondarily to the bacterial infection, the color of the urine is milky. So it's a kind of a milky discharge along with the urine, which is called the chyluria. There can be secondary epididymitis, and there can be hydrocoele. So always keep in mind the symptoms like the fever, chyluria, hydrocoele, and epididymitis. They're particularly the clinical features for the filarial elephantiasis of scrotum. So there can be a non-filarial elephantiasis of scrotum as well. But first of all, we'll be discussing about the treatment for the filarial elephantiasis. So the treatment strategy is usually you put the patient on a pharmacological therapy, you put the patient on albendazole, you put the patient on diethylcarbamazine, and you put the patient on ivermectin. So in case of the larger wounds involving the larger area of the skin, obviously we are not left with any other choice except excising the lesion as much as possible, and as much preserving the normal architecture or the normal anatomy, not disfiguring or compromising the function of the organs. So the treatment strategy for the filarial elephantiasis is to put the patient on ivermectin, albendazole, or diethylcarbamazine. And ultimately, if the lesion is too large enough, what you do is you can put the patient on the surgical treatment regimen, like the excision of the lesion. The other thing which is also important when we are discussing the filarial elephantiasis is the non-filarial elephantiasis. So you can see here, like non-filarial elephantiasis is a kind of the elephantiasis which is not because of the infection, like the Vaucheria bancrofti. There can be, other causes for the pelvic. Ultimately the basic mechanism is like the pelvic lymphatic system is obstructed. So there can be other causes as well which are obstructing the pelvic system. So the conditions including the scrotum also involve the kind of the sebaceous cyst. You can see in the diagram they're tiny multiple sebaceous cysts which are involving the skin of the scrotum. If they're small enough, there's not much to do about them. You can leave them unattended. But if the sebaceous cyst is a typical identification for the sebaceous cyst, that they have a punctum just at the top of there's a round circular lesion, but at the top of that circular lesion there would be a punctum, right? So if the cyst is a kind of a small sebaceous cyst, if it's not affected, it's not causing any pain, they can be left untreated. But if they are infected, first you give the antibiotics, you treat, you put the patient on conservative management, and when the infection is settled, you take out that, you excise the sebaceous cyst. But sometimes a patient can present to you with a ruptured sebaceous cyst, and that's a kind of the surgical emergency. You put the patient on antibiotics, plus you do the surgical excision as well. So this was about the conditions which are related to the scrotum. Although the carcinoma of the scrotum is not very common, but because it's a kind of the rarest tumor, especially in the Indian and the South Asian countries, the carcinoma of the scrotum is very, very rare, almost. It's nowhere. But initially it was thought that it's a kind of the occupational tumor, and it's related to particularly it's related to the occupation. But with the passage of time, research and other strategies and other studies, they indicate that it has nothing to do with the occupation, particularly mining or sandblasting, particularly the penile cancers are common as compared to the scrotal cancers. And how they develop, they actually develop as a smaller lesion, a small ulcer, and it ultimately lead to a full-blown cancer. If we particularly talk about the features of the carcinoma, so most of the time there are aromatic cyclic hydrocarbons which are causing the carcinoma of the scrotum, and their growth usually start as a wart, or their growth usually starts as an ulcer. And because it's not only because when they are locally invaded, we know that the scrotum skin is actually enclosing the testes. So sometimes when they're locally invaded, they involve the testes as well, and sometimes ultimately you have to go for the surgical excision. So always keep in mind that the scrotal tumors, they're not very common, especially in the Indian South Asian population, and somehow they're similar kind of the tumors like the penile tumors or the carcinoma of the penile shaft, and they're usually occupational secondarily to the mining and cell blasting and all the industries related to the achromatic cycle of hydrocarbons, right? And their growth usually start as a typical small lesion, a wart, or the ulcer, and when they are locally invaded, they involve the testes as well. So sometimes there is a local involvement as well, like the involvement of the there can be involvement of the inguinal nodes as well. So what you do, you surgically excise the lesion, and you also give the antibiotic for the large nodes. And sometimes when there's a metastasis, then you can also go for the radical dissection of the inguinal nodes, or which is called as a bilateral groin dissection. You can see here in the diagram, what you do is you surgically excise the scrotal skin, and you also combine it with a bilateral groin dissection, and you just remove the lymph nodes which are being drained by the carcinomatous cells. So this was about the conditions of the scrotum. We have discussed so far about the acute inflammatory processes. We have discussed about the elephantiasis, and we've discussed about the carcinoma of the scrotum. But there is another thing which is which needs to be discussed here, is about the male factor infertility. Infertility is basically defined as inability to conceive for a duration of at least 1 year, right? But despite of the regular sexual intercourse. But the causes of the infertility are, there can be a male factor infertility, or there can be a female factor infertility. The most of the infertilities which are taking place, almost 15% of the infertility, is because of the male factor. So whenever a couple is coming to you with the complaints of the infertility, you need to evaluate both the partners. You need to evaluate the female, and you need to evaluate the male as well. So if we particularly talk about the process of the and they're kind of the genital organs like the testes, and they're under the influence of the luteinizing hormone and the follicle stimulating hormone, and they act on the Leydig cells and the Siltley cells, and testosterone is produced, and that testosterone is responsible for the production of the sperms, right? And then sperms are then transported all the way from the testes to the epididymis and the vas, and through the vas it goes to the prostatic urethra, right? To the penile urethra then. And there are kind of a lot of glands which are responsible for the semen secretion. Almost a count of sperm count of 15 million sperms per milliliter is considered to be a healthy sperm count for the process of conception, right? So if we particularly talk about the etiological factors for the male factor infertility, there can be testicular causes, like testicular causes, like they can be cryptorchidism. There's a microdeletion of the Y chromosome. There is a testicular atrophy. There's a chromosomal abnormalities. There can be secondarily infections like the mumps and orchitis, and we know that mump orchitis ultimately lead to the testicular atrophy and the infertility. There can be various drugs which also cause the infertility, and there can be radiation damage. So if you are thinking about the male factor infertility, always try to find the cause, etiological factor like the Klinefelter syndrome, microdeletions of the Y chromosome. There can be testicular atrophy, there can be testicular agenesis, There can be chromosomal problems. There can be mumporchitis. There can be cryptorchidism, which is also related to the testicle malignancy as well. And there can be, the causes can be radiation damage, or the causes can be particularly drugs. One entity is like the testicular causes, and the other causes is obstruction, right? So there can be obstruction somewhere, because we know that sperms are being produced in the testes, seminiferous tubules, and then they go to the then they go to the epididymis, and it is then transported to the vas. So there can be obstruction starting from the epididymis till the vas, or there can be, conditions. There can be epidydymorchitis, there can be epididymitis. So always take in mind, when you are evaluating the male factor infertility, ask for or evaluate for the microchromosomal lesions or chromosomal abnormalities, Klinefelter syndrome, mumporchitis, and other obstructive causes like the epididymitis, or there can be congenital absence of the vas deferens. Like there's a condition which is a cystic fibrosis, in which there is problem with the chloride channels, and the transportation of the sperm is also a factor leading to the infertility. And in cystic fibrosis, there's a congenital absence of the vas as well. Or there can be, whenever maybe inguinal hernia is being repaired, or chydectomy or is done usually. So there can be surgical damage to the vas. So surgical damage of the vas can lead to the obstruction and causing the male factor infertility. And other causes, there can be epididymitis. Now, the question is, how you are going to assess and investigate a case of male factor infertility, right? First of all, the thing is, you're gonna take the detailed history, and then you're gonna go for the detailed clinical examination, checking out for the cryptorchidism, checking for the testicular agenesis, if bilateral testes are present in a patient or not, or there's a history of radiation damage or something, and then you have to examine the patient. Now, always keep in mind, whenever you are assessing the male factor infertility, always assess the factor of the female infertility as well. Careful taking history. Sometimes there can be agenesis of the testes. Then you have to assess the woman's status as well. And then you go for the part of the investigation, right? And in investigation, you go for the semen analysis, in which you actually, there's a total sperm count, the amount of the number of the motile sperm and the immotile sperm, the total volume of the almost 15 million sperms per ml are considered to be healthy. And if the semen analysis is normal, or there can be oligospermia, there can be azoospermia. If there's an oligospermia, that means that actually the sperm, there's some production of the sperms, but it's deficient or it's decreased. It's not up to 5 million per ml. Or there can be azoospermia, or there's no production of sperms at all. And then you screen for, when you're done with ultrasound and you are sure about the presence of the testes, there is no undescended testes. Testes are viable and they're present in the scrotum. And then you think about the hormonal factors. You think about the LH and FSH, because we know that higher up in the center, in the pituitary, from the anterior pituitary, there are important hormones like the luteinizing hormone, follicle stimulating hormone. So these hormones are very much important because they act like LH is acting on the Leydig cells, FSH is acting on the Sertoli cells. So actually, they have important role to do in the process of the spermiogenesis. So you need to take a detailed, careful history. You need to examine, you need to palpate the testes, you need to assess the woman as well, you need to go for the semen analysis, and obviously FSH and LH testing. So when you have already done your clinical assessment and you have identified a reasonable cause for the male factor infertility, then what you're going to do is you're going to treat the patient, right? And how you're going to treat the patient, it depends upon the cause, right? If there is micro deletion of the Y chromosome, obviously there's not much you can do. And the fertility is a kind of the permanent infertility. And if there's a mom bronchitis, or treat the mom bronchitis, and it depends upon obviously the treating the reversible causes. And reversible causes, like there can be obstruction, there can be epididymitis leading to the obstruction, there can be kind of damage to the vas, and you can obviously repair the vas whenever, if the surgery, if the vas is damaged during the surgery. So treat the reversible cause, and you can, if the the cause is irreversible, there's not much you can offer. But if the cause is not very much reversible, then what you're going to do is you're going to assist the process of the conception, right? And you go and you perform the testicular biopsy. There's another important investigation, which is the vasography, whole of the tract, or the testes, epididymis, and the vas. And if there's any kind of the obstruction, you can find out to have. And sometimes if there's obstruction to the pathway, epididymis and the vas, and the pathway is obstructed, and there's a hindrance to the transportation of the sperms, what you're going to do is you're going to do the bypass operation, right? So you can also go for the assisted conception, like the intracytoplasmic sperm injection, or there is another important entity, which is the in vitro fertilization procedure. So what you do is intracytoplasmic sperm injection. Actually, you try to load the cytoplasm of the egg with the sperm, and then obviously they mate each other by a natural process. And there is another important procedure you can use, is in vitro fertilization. So what you do in in vitro fertilization is that you collect the eggs from the female, you collect the sperms from the male, and then they are kept together in a test tube, and a favorable environment is provided to them to come closer to each other, and they mate in a natural process. So they're also called as the test tube babies, and then the fertilized egg, or the zygote, is then transported back into the uterus of the woman. That's how the infertility is treated. But always think that it's not like that you have to treat the male factor infertility only. Sometimes there can be a varicocele as well, but the studies do not actually they tell you regarding cure of the infertility or not. So always go for the female factor assessment as well, because sometimes there is both a male factor and a female factor responsible. And if you treat the male factor infertility, the female factor infertility is not treated, and because of that, there are various problems that can be caused. There's another important thing when we're discussing the male factor infertility, is a permanent sterilization of the male, right? And how you do the permanent sterilization is through the vasectomy process. This is a surgical procedure which is called as a vasectomy. But before that, you need to counsel the patient that this is a kind of a permanent procedure, and whenever you are doing this surgical procedure, after that you would be sterile male for the rest of your life, right? So it's a kind of the permanent contraception, just like the contraceptions available in the female, like the intrauterine devices and the contraceptive pills. And sometimes obviously those intrauterine devices are actually placed for 5 year or 7 year, and then the permanent contraception is like causing the bilateral oophorectomy or bilateral salpingo-oophorectomy or salpingectomy, right? BTL, which is bilateral tubal ligation. But in male, the process of the permanent contraception is a vasectomy, and how you do this is like you can see here in the diagram that this is the testes, that is the epididymis that is crossing over the part of the testes, and from there, this is the tail of the epididymis, which is connected to the vas deferens. And we know that vas is then entering all the way, going to the spermatogoad and sliding over the surface of the bladder, and it coming through the prostatic part of the urethra, ultimately to different bulbar in the penile urethra, and ultimately coming to the coming to the penis. But how you do this vasectomy is like you give a sometimes you open the skin with a small scrotal incision, or sometimes a bilateral incision is given, and a bilateral vasectomy is done. The vas deferens is divided. It's a one is the proximal part, and the one is a distal part. There's a distal part, and this is the proximal part. So what you do is you ligate the proximal part, and the distal part is left attended, because you break the connection. So it's a kind of the permanent contraception when you actually cause a hindrance to the transport of the sperm by dividing the vas and ligating the proximal part. But you need to counsel the patient that there can be sometimes the procedure, there can be complications of the procedure as well, and sometimes because you do a one-sided vasectomy, the other side remains viable for the transportation, and you cannot achieve a full infertility because of that. So that's how you do the vasectomy, right? And you can see here, this is in the diagram, that this is the vas deferens, the prostate, the bladder. You divide the vas just proximal and distal, and the proximal part is ligated and then separated. And you can see here the epididymis as well. So again, sometimes it's open by a small scrotal single incision, and sometimes you give us incision at two different sides, and you divide the vas bilaterally. That's how the process of the vasectomy is performed. So far we have discussed in today's lecture about the conditions of the scrotum, the filarial elephantiasis, the non-filarial elephantiasis, and obviously we have been discussing about the carcinoma of the scrotum, and at the end the important topic, which is the male factor infertility, the causes, and obviously the treatment for the male factor infertility. So that's all for today's lecture. For other lectures, keep watching sqadia.com. Thanks for watching sqadia.com.